Brilliant, brilliant. So basically, let me just go back. I'm here this evening to talk to you about advocating self-care following a caesarean section. And do you know why I chose this topic? I chose this topic because I feel it's so important just lately. Someone said to me just last week, "Oh, Janine, caesarean sections, it's your thing." Well, it's been my thing since 2017, simply when a student midwife said to me, "Janine, that idea you've got and that way you're talking to that mother, it's really fantastic, and I really think you should be sharing that idea." And that idea was born out of the 5 guide idea, which we're going to go into later on in the presentation. But it was a student that inspired me to submit an innovation to the RCN Foundation Innovation Awards. And that was about celebrating practice, 100 years of practice. And since then, I've been driven to think about caesarean sections and why they've become my legacy of my career. Well, I'm now in my ruby wedding years of being in the NHS. That's 2 decades where I spent in acute care, nursing and midwifery, and then 2 decades plus 5 where I've been in primary care, leadership and management. I don't think of myself at the moment as a nurse or a midwife or a healthcare leader. I think of myself in a series of A-style people. And I'm going to tell you that I think, first of all, the title gives it away. I see myself as an advocate for women and families. And I've been given the role as an ambassador with the Personalised Care Institute, and I'm also a Core 20+5 ambassador. I also think of myself as another A-style sort of person, as an activist, and not only an activist for healthcare, but I'm also a seroptonist. And I'm also an advisor. And I'm an advisor for Surgical Site Infection Network and the National Wound Care Strategy. And then I became another A-style sort of person. I became an author by accident during the COVID, as Sue said, when resources were down. I co-produced with Fiona Rastus, who should be online this evening from Australia, a manual C-section recovery manual. And that A part of me was all my experience, knowledge and skills coming into the fore and being put into words as a legacy read for mothers. 2 more A people I am. I'm altruistic. I like to put others first. And my final A is that I've become a bit of an avenger. No, I've not got my big gold pants on, but I do put those on at times when I have to, when I'm particularly wanting to look at women's health rights. But just as we stay on the title page, my overall aim has been to empower birthing women to value their own recovery, their own needs, and support all healthcare professionals who do look after women with some simple tools to share with mothers and make their life and their working day a little bit easier. So tonight's webinar, and thank you for letting me be here again and being your only speaker and not having to share the platform. It is really about advocating that self-care following the C-section, and it's how we support and enrich anyone tuning in this evening, and the importance of self-care and the importance, the difference it'll make. It's a gift that we'll be able to give through knowledge, through conversation, and the quality of our conversation. And I'm going to be giving you some top tips. So it's all about getting a good balance between what matters and what is meaningful. It's a bit like for those of us who are in the maternity trade, it's about really looking at a little bit like our work-life balance. So really, there are some good pictures and some graphics in here. I hope I don't upset anybody, but there will be some graphic pictures. And for caesarean section, for most student midwives, it's the first time that they're going to see blade to skin. Because, you know, within your training, the first time you do see a caesarean section, it's quite magnificent, but it can also be quite traumatic. And it's the first time that some mothers actually have surgery, and it's major abdominal surgery. And it's the first time that some partners ever get to wear the scrubs and enter a theatre. So whatever your journey into theatre is, I want to help you and those around you who are personally involved to be able to self-care following that experience. So what are my webinar aims today? I'm hoping that we can explore the rising rate in caesarean sections across the UK. That's important because they're on the increase. So you'll be seeing what, and I'll be able to present that to you. I want us to discuss why healthcare at home is an important topic and why it allows women and why we should be helping women to enhance their decision-making skills, and share with you the 5-guide bundle of care to support you in clinical practice. Behind me, you'll see a hand, and we're going to go through what 5-guide is. It's a visual tool, and you're going to go away knowing how to use it. But then I want you to embrace more openly the benefits of self-care and how you can continue to support birthing mothers to process what's happened to them with health information. And even after you've discharged them, you'll still be making a difference to those families and those women. I want you to be able to gain some ideas and explore the components of self-managed care and enhance care with top tips, how we can use some certain products, our training, and the quality conversations that we will have with women. And finally, I want you to take something away with you for you to do, and I want you to explore a positive change for you in your local maternity services and the care offer that you offer. So let's have a little look at where we're at here. Slide here says, are current rates of C-sections rising? Now, they are, and we're going to explore some data. And some of this data is nearly 2 years old, but the beauty here in front of you, you've got some great infographics. And the red highlighted 52%, 41% and 45%, you can see here, are a breakdown of the percentage of caesarean sections that have gone on within the infographic here that you can see within those hospitals. So statistically in England in 21 to 22, there were approximately 203,746 caesarean sections performed in the UK. 44% were planned. So we knew we were going to have one. We'd made a choice, and before the onset of labour, we were prepared. But 66% were unplanned, and they were performed during labour or following an uneventful induction of labour. Between 2011, 2012, and then another 10 years on, 21, 22, the number of procedures performed annually increased by approximately 40,000. Now, these figures are really important because as we go through the presentation, I want you to jot down, remember, and keep some of these figures in your head. But the percentage of total births in that period, 21-22, are recorded to have increased from 24% to 35%. Yet when we look at the infographics, in the first 3 infographics that I'm showing you, actually 52%, 41% and 45% are C-sections. Let's have a look at unmasking some more C-section rates across the NHS. What I like about the infographics is that it's shown on Instagram, it's shown on Facebook, it's actively talked about on maternal and chat websites. Women can see them quite clearly, but basically the Instagram is putting a set of figures up there But if we go again along here, 30%, 36% and 39%, we can see it's telling us a story around the increase of caesarean section rates across the NHS. The infographics, I can say that are the prize-winning application of our maternity and neonatal voices, breaking down data so that women can see what is actually happening. But I've just chosen a small selection of what we can see with regards to C-section data. Let's have a little look here. So in this slide, I want to talk about policy versus reality. Caesarean section, is it literally a choice? Is it a dilemma? Is it a personalised care investment? For me, personalised care, this is how I've ended my NHS career as a personalised care project manager. And what I've valued from personalised care is that the values it gives individual service users, the voice of what matters to them the most is so important. How they can have control over how care is delivered, how care is given, what choices they make, and the preferential needs of that individual. So personalised care as a choice and an investment is not only policy rhetoric, it's also a gift for us to be able, as a service user, to be able to ask questions, demand to know more, be able to say what matters to me, rather than the medical model of things that are just done to us. So it's an investment in what it is we want. And that policy rhetoric with regards to my statement there is caesarean section, an NHS dilemma, or is it an investment, is because it's backed up by policy rhetoric. So in Better Births policy, it started there really with personalised care, putting women at the centre of care and the decisions that they'd made. And then in recent years, personalised care has not exclusively been given to maternity services. We're using personalised care more in primary care, GPs, pharmacies, new roles have been created, healthcare coaches. So people are asking more, demanding more from a NHS that is under a lot of strain. It represents a big shift by the NHS in its 5-year forward policy. And it brings us up to date with personalised choice being part of the long-term plan. It's all about the money versus the care. We cannot and have not got an endless budget in the NHS. So now where we're at, we're in maternity services, we have personalised care plans to support the choices that women can make. And one of those is continuity of care, although in some regions that has had to be halted because obviously we have a dilemma with workforce, and services have had to be changed in order to be safe and in order to manage those effectively. And then our other policy and recommendations have come from other reports like the Ockenden reports, obviously recommendations. But here what I'm presenting to you as well tonight around the dilemma side of it against the policy side is that the average cost of a caesarean section is around £7,000, and that's if obviously looking at it, that's not going into private healthcare, because if we really could add up how much it is for the anaesthetist, for the time in theatre, for the days that you occupy an NHS bed, the monetary costs are much more expensive than a vaginal delivery. So again, when we talk about choices, it's so important that we think about antenatal care, that we help women to make the right choices. Sadly, you know, with every operation, there is also the risk of other things that can happen to us. And surgical site infection is one of the most cited post-caesarean morbidity data that we have. Even pre or post-operative intervention rates are relatively high. And unfortunately, 1 in 20 women will suffer a surgical site infection post-surgery. Now, it is actually higher, and I've numbered some references there. It's higher in women who have emergency sections. And most surgical site infections are not diagnosed until after discharge from hospital at around day 5 to 15. Day 5 to 15, there's a big change in who sees women. There's a big change in the clinician who sees women. It'll go from maternity care and quite often going into health visiting care. And the cost of managing surgical site infections post C-section is around £5 million annually to the NHS, which is roughly 2/3 of that is for hospital-based costs and 1/3 is for community-based care. Because if we look at the timeline at the bottom of how long women stay with us after a C-section, we can see that women are most likely to be discharged at around day 1. Women don't stay in hospital very long after a C-section unless there is a need to have intervention, or there may be some other issues. Twins usually stay in a little bit longer, or to establish breastfeeding, or if there are any obvious physical difficulties. But throughout the trajectory there, women will be seen around 7 times. So let's have a little look at why is healthcare and health-related self-care care is fundamental. Let's have a look at the problem here. Early discharge. Well, early discharge as a problem is going to limit the opportunities, as I've said, for midwives to perform wound checks beyond day 2 to day 10. Solutions around that, obviously, it's important that we think about shared care, which is predominantly where we work with other co-productive teams. For example, how we work with our health visitors, how we work with our GPs, how we work with tissue viability teams, how we manage women to support their own self-management, and how we look at discharge cooperatives, how we actually support women beyond our discharge date, from hospital, from community midwife, onto health visitor. And another solution around that about early discharge and wound checks is obviously, I'm going to go through later on in the webinar, the 5 guide and the teach back. It's how we can impart this information so that women can become part of their own healthcare at home team. Another problem there we've got that women often come to postnatal wound clinics or postnatal clinics because of staff numbers. Women are having to leave home after a C-section, and it could be anything to day 2, day 3, travelling in cars to come and see a midwife in a midwife-led clinic. And that's very difficult for some women who've had a C-section. And as I said, the onset of problem of surgical site infections is around day 5 to 15, and 1 in 20 women will develop a surgical site infection or a wound dehiscence. So self-care as a solution, again, is very important. And the daily scar tracker, which is in the book around self-management. Now, I've got here, not a makeup mirror to check to see if my makeup looks nice there or anybody. The importance of this mirror is that it cost me £1, but you'll see in one of the images later on, one of the slides, the importance of a wound check at home with the purpose of having a wound check mirror is so important. And the education of how you can encourage a mother to become part of her own wound care team and how she uses a mirror to check her wound. And as another solution is the opportunity for online education resources, discharge videos. A problem around communication between healthcare professionals is usually around day 10 or 14, when acute services and maternity and midwifery services then change and hand over care to health visiting teams, because the communication around that is very, very scanty. There is no state of wound discharge handover quite often for a woman who's had a C-section. So the quality of handovers, if they're not recorded, if it's not data written, you can have one health professional not knowing what has happened to a woman previously with a previous healthcare professional. And that as an agenda in itself is part of the operating procedures that can happen within organisations. Another problem is that, wound care training and competencies vary. And a solution to that is how we access competency-based, role-specific training. And I've highlighted in here, just shared with me this week from the Surgical Site Infection Network, is a great little video about looking after your surgical site wound on YouTube. And I know you'll get access to these slides, so it's worth doing the hyperlink to that. Another problem, discharge information. It's sporadic, not consistent. Well, in the future, it can't be like that, because we've got solutions coming. We've got national wound care standards that are going to support us. We've got surgical site infection networks. We should be looking at having standard operating procedures. We can have quality improvements. We can have innovative midwives creating work with their maternity voices to create great maternity patient information leaflets so that they can take home. Some women have reported that it's a problem that once they're discharged, it's very baby focused. Well, we've got to advocate self-care, family care, and the importance of sharing information with women, that their wound check is as important as us doing a baby weigh and doing the baby's heel prick. And establishing breastfeeding. All of these things are so important, but there's so many things that we as clinicians have to remember. Caesarean section wound care is getting a big boost from National Wound Care guidance and NICE guidance. Solutions are around standard operating procedures again. If we have those in every unit, we'll be able to have consistency and sustainability, equity and equality in what's happening with wound care for all women, nationally and internationally. And then wound care costs are escalating. They're escalating because the rates are going up. I've told you that an average one can cost around £7,000. So that's a big draw on the resources of the NHS. But we need to reduce the risk, and prevention is better than cure. We need to educate and share the responsibility for our care after discharge, so that we don't have increasing surgical site infection and wound dehiscent issues on top of the expense of a C-section. A mother's experiences of caesarean care as a problem, it's been negatively reported on Instagram, on Facebook, in the media. And, there's a lot of work going on to put back, to give back, to listen to women. And through Maternity and Neonatal Voices, I have to say that, they're a great platform for you doing your surveys, for you to get in your maternal voices heard, and then putting that back into the clinical practice and innovations within your local maternity nursing services. And finally, a huge problem I've seen in the press, a lot of health organisations on the naughty step. And I say the naughty step because it's, the Ockenden reports, legislation, a lack of zero tolerance by members of the public, they're all valid there. We need to be honest, and we need to have solutions about how we're going to put right these wrongs, and quality improvements and innovation are the way forward. Now, caesarean recovery, and as I've said, what's happening at a national level. Policy's there to support us, but we need to understand, what isn't there. We've got the long-term plan, which is absolutely idealistic, And we should be working towards all of the things within the policy. And if we use personalised care, shared care, supported self-management, some of the things we are going to be able to achieve. However, if I think also about what's happening at a national level, from Nursing Midwifery Council, we've got obviously competency issues where potentially there may not be role-specific training on wound care. We could find that the first time we ever come across a wound as a health visitor, we may have had a background in mental health nursing, or we may have had a background in learning disabilities. And we have to look at our competencies to know that we have a duty of care to speak up if we're not competent with wound care or any issues that we're coming across for supporting women with their caesarean recovery. National Wound Care Strategy are working towards developing strategies that now will become more familiar with ICB boards and hospital institutions, because they'll have to take notice and they'll have to create operating procedures. Just as the Ockenden report has said, we can't be on the naughty step. We've got to always be on our game. We've got to be always improving and developing our quality, risk-free, safe maternity care so that women can enjoy having their babies and there isn't that knock-on effect of the naughty step scenarios which we find ourselves in and can be quite debilitating to the service and the profession. So when I look at this, on moving on to slide 8, could you interpret and act on some of these wounds as clinicians? And they are quite graphic. But those of you who are not nurses and not healthcare professionals who are online tonight, these pictures are so important to me because I've come across so many wounds like this as a clinician, and that has led me to be the speaker I am today, to be that A person I've told you who I am. Because these wounds mean something to that woman behind that picture. And it's what matters to these mothers that really matters to me. And that's what self-care is all about. It's about how we can interpret a wound when it's seen, and how we can act, and how we can signpost, and how we can prevent, and how we can improve, and how we can make better things for women who have surgical wounds that can become like this as they progress through their postpartum recovery. We need to be sepsis aware because we know C-section is major abdominal surgery. So we need to be able to share with women, what does a good wound look like? What does a bad wound look like? Why do you want to use your mirror? I know it sounds a lot to have in our backpack of knowledge for the short time that we have with ladies, but these are so fundamental. Caesarean section wounds. What is a caesarean section infection? A surgical site infection. What's the difference between a wound? Some healthcare professionals without appropriate training won't know the difference. We need to also be looking at, if we don't tell women, they'll forget. Show me and I'll remember, but involve me and I'll get to look after myself, just as I'm saying there in the quote. Mental health and women's mental health and trauma is so important because it's all related to the issues around recovering from caesarean section. And we want to reduce any opportunity for an increase in any obstetric violence, any obstetric upset, any emotional upset. Pain management, bladder and bowel movements, mobility that's reduced, protecting and safeguarding our women, raising concerns as clinicians if something's not right, or you haven't got the competence, or you see something and you didn't know what to do with it, or you came across something and you had to refer somebody. Protect the profession, protect the patient. We want to improve equitable access to care the availability of recovery services. Now, in the new National Wound Care Standard, they talk heavily around scar massage, but scar massage is not available on the NHS. So we have to think about what women can afford and how we can also impart that knowledge and skills for self-care and recovery, and access to physios, health visitors, GPs, so that they know who they can call when and if it's needed. Antenatal education is so important. We have to talk more about caesarean sections, because as the numbers I've shown you, they're increasing. And if 66% of women weren't expecting to have a C-section and ended up with a C-section, we have to talk about the good, the bad, and what is likely to happen in order to get women prepared for the possibility. Our postnatal communication has to be health literate, and we have to consider how we cater for all cultures, religions, and complexities. And we have to have a support network with our families, our parents, our grandparents, our partners, so that everyone else can help us to recover. Because if we focus on breastfeeding and attachment and bonding, they're only two components of the transition to motherhood when you've had a C-section. If we don't focus on their wound care and we don't help signpost them to resources that can help them to recover, then we're forgetting some of the what I said in the opening statement. You know, it's really about what we can do, what matters, and what a difference we can make for women. So how can Five Guide help you in practice? Do you know, we've got the power in our hands to start that conversation, and it's so health literate that it's not reading, writing. It's the power of what we've got in our hand, because literally it's a digital world we're in, and if we use our digits, we can digitally help share some information. It was developed after that student nurse heard me using this to a lady and just saying to the lady one day, do you realise you've got up to 5 layers healing? 5 layers: your skin, your fat, your muscle, your peritoneal, and then you've had an incision into your womb for your delivery of your baby. It'll take 5 or 6 weeks to heal. Once the power of your hand is used to explain the anatomical recovery, it's amazing the first time you use it with a C-section woman, because quite often women would say to me, well, nobody's ever told me that before. And Five Guide, you know, it's so simple to start and open up your conversation on self-care and on your health promotion messages. Everything else, you'll have consistency, you'll have sustainable resource there. It's free, it's visual, it's easy to be interpreted, and it complements all your other self-care resources. It's on screen there. There's a great teaching video for you to follow as well on YouTube. But it's a sign of parenting to get moms to understand what's happened to them, so that then they are not afraid to ask for others to help them to recover. So let's go back to the reality again on the mandated home visits with regards to the reality of visits here. 7 mandated visits. And in some areas, I know that some of these are even reduced to between the day 2 and the day 5. It may not be a midwife, it will be a maternity support worker, which they may not look at a wound, and they may not have the competency and skills to spot those differences at a time when a wound could be breaking down. Because if you recall, I said between day 5 and day 15 is the classic time for the 1 in 20 women to have a wound breakdown. If we get 7 mandated home visits that last approximately 30 to 45 minutes in our postpartum period after discharge from hospital, we're lucky to get 4 hours with a healthcare professional as a new mum. That leaves 41 days of self-care opportunities where you, with your skills, knowledge, can impart to a mother what she can be doing in those 41 days. That's quite powerful. I had never really thought about it until I looked at self-care and what it actually meant to how many days I would be in a position to be having to look after myself and thinking, am I doing the right thing in my recovery? Here we've got the self-care continuum, and if we look at from Self-Care Forum, if we look at day one on my right, where we've had major abdominal surgery for whatever reason, why is the self-care continuum and the self-care agenda so good for women? We want to empower them. We want to empower them to care for themselves because we know we've got to let go of them over a period of time. It is more cost effective to the health service. It increases our own personal responsibility for our health and our own healthcare needs. And ultimately, as I've said, it will ensure some form of financial stability on the NHS. Where are we on the scale as a mom? As I've said to you, day one, you're in pure medical care there. You still have the need to have professional overview and being seen. But if I've said to you there are only 7 mandated visits, and I'm back on that slide, this is the transition of where self-care is so important. It is so important that we take a mum on a journey to go from acute care at surgery to primary care within her recovery. And we share that care, and self-care becomes combined to then becoming pure self-care once you discharge them. However, the NHS is going to always be there for these women, these mothers, these families. It's the transition and the timeline that I wanted to just emphasize over that 41 days in the postpartum period. And really, what I want to really emphasize there is there are 7 pillars of self-care, 7 pillars around where we can help women in developing an understanding of what self-care is. And it's how we give women something to believe in. And it's how we as clinicians also have something to believe in and not just something else to do, because we have enough to do. We certainly have enough to do, but it's how we as a workforce, with our pearls of wisdom, can make a difference that can continue to make a difference even after we've discharged mothers. So if we consider the pearls of wisdom, we need to impart good knowledge and health literate information. The 5 guide is your classic way in. It's consistent, it's sustainable, it's award-winning. It's your first conversation that you can have with a caesarean section lady. It'll allow you to go into talking about her mental health and well-being. If you use a teach back method all the time, you can then reiterate that. Did you understand what I was saying? Well, do you realise how many layers you've got healing? And if she can then relay back to you, well, I've got 5 layers healing. And don't think just when you look at the skin, that's healed, because you've actually got another 4 or more layers inside that I'll take to heal. And the woman is obviously then taking in the information around what abilities she'll have for her physical activities. She'll be able to learn to know her limits. She'd have hopefully got her support network sorted, and generally eat a good healthy diet, do risk avoid activity, not smoking. All of these are your health promotional wisdom and pearls that you can pass on. Good hygiene. It's so important to reduce the bacterium around a wound. So obviously good wound management, how we cover the wound, what we wear, and the rationale for using products in the self-care period. We've got 41 days here where we are not constantly seeing health professionals. So we want to make mothers aware that antibiotics. We don't want to use them all the time. So if there is a wound and is a problem and you are using your mirror, how we can get you seen early with a doctor, how we can use products to support our wound, and how we can manage it. So our pearls of wisdom are really important in how we ensure that women in those 41 days on their own are doing great healthcare at home. This is a slide that really shows you a little bit of visual reality of what it's like for mothers at home. Washing, cooking, cleaning, ironing, bleeding, aches, pains, breastfeeding, all of this is going on, and all at the time we're learning how to be a mum at the same time, as well as recovering from major abdominal surgery. Let's have those quality conversations, because the quality conversations that you can have, and this slide, it always amazes me, you know, do you need anything? And then she says no, but literally look at the things that she needs there. As a mom, she probably, you know, would love to tell you, if you ask me what matters and you really can listen and you've got time to listen, you can help me to achieve those things. Because what is happening to some mums is, you know, they're in pain, they haven't had a shower, haven't had a wash, haven't had anything to eat, and they really don't want to trouble you. They're quite stoic. They don't want to be seen to be suffering in any way or shape or form. But it's a sign of good parenting to say, actually, I'm not coping well. It's a sign of good parenting to say that, and it's how we have those quality conversations to encourage mums to tell us what they need. So caesarean section mums, literally, you know, we can help them with their practicing. We can help them by, you know, creating a supportive network. We can help them by choosing something simple, handheld mirror. We can ask them to tell us their concerns. We can ask them to invest in a daily nap, get a chore list done, eat well, ask somebody to do me some lunch food packages, you know, have a little look at the possibility of understanding my inner healing by using the 5 guide. We can remember that our discharge is not that you're healed, we're still available to you. We want you to know who to contact. So we're creating a social model of care instead of sticking to the medical model of care, because we expect them to inject themselves with Clexane. We expect them to take their prescribed medications. So if we think about self-care, we can also help them with the other sides of their recovery. The book's packed with loads of ideas. It really is around self-care, recovery top tips. But I did say that when I opened up the invitation, that I would ask you to look at your own possibility of change in your own organisation. And I'm going to just go through very quickly because of the time. I would like you to recognise your own training needs. I'd ask you to say to yourself, what sort of change agent are you? It's self-care next week. Why not become a champion? Ask your local maternity service if they've got a caesarean section standard operating procedure. Ask yourself, am I competent to assess wounds? And ask yourself, have I the tools then to document individualised care plans? How can you make a difference by doing what matters? Does your maternity service have a personalised care champion? If not, why not become one? Think about personalised care as something to believe in and not just something else to do, because this is what we do. And help mothers to understand why self-care is so important, and hand back some responsibility for them by giving them some simple tools to help themselves. And how can we consistently maintain equity in caesarean section recovery? I did this, wrote a book with Leonie, as you've seen, and then decided just before I was leaving personalised care position, I helped the Maternity and Neonatal Voices of Derbyshire put together a survey, of which, going through the list there, what upset me the most is that 52% of mothers reported they felt comfortable to monitor their own wounds. So women are more than happy if they've got the knowledge and skills to self-care and monitor their own wound. And they favoured a more personalised wound care plan by 83%. Show me, tell me, and I'll monitor it. And Scar Tracker, which is in the book, is an amazing way of keeping an eye on your scar. So summarising and coming to the end of the presentation, self-care is not no care. So self-care is about individuals understanding and practicing activities that protect them more. Protect them in those 41 days. We're not there. It doesn't mean we're abandoning them. It's about supporting self-care and empowering their own control. People mustn't feel or be made to feel like they can't seek help. They don't want to, they don't want to interfere with our day. They know we're busy and they need to know that they can come back to us because we don't want them suffering any ill effects. And Self-Care Week, as I said, next week, you can become a champion and they've got a fantastic lot of resources on there. And they've given us the book, the award this week, which is absolutely fantastic. So my digital thank you to you tonight is, remember, it starts with the power you have in your hands. You have the gift to pass over these skills to mum, and you will help mums to take control of their recovery. I've popped that on there, Sue, because I think it's a great way of getting the book to be shared amongst clinicians, but it's a great way for also mothers to learn how to self-care for themselves. And anybody who's watching tonight, you don't have to be in the maternity profession to share the book, because it's cheaper than a bunch of flowers, and it means so much more to be able to self-care. So don't ever underestimate the impact your conversation that you can have with moms and the families. Give them the confidence to allow them to self-care for themselves. And it's a sign of good practice to encourage self-care, but it's also a sign of being brave and being a good parent and a good mom to ask for help. Thank you.